Hello to everyone. Today we are going to have a guest again among us, a guest from World Health Organization. Before hearing her, I will try to make a brief introduction. I hope you see the shared screen. This is our poster. If there is any problem in seeing this, please warn me. It is the 7th meeting of Association for Community Mental Health Promotion in collaboration with the Psychiatry, Medicine and Primary Care section of WPA, World Psychiatric Association. Our guest is Director of Department of Mental Health Substance Use of World Health Organization. Well, I was saying World Mental Health Organization. Maybe one day that may also occur. Let me try to introduce our guest. Olga Karpenko is a senior mental health policy specialist with more than 25 years of international experience in Europe, the Caribbean, and Latin America, implementing and advising governments on national policies related to mental health systems. She is a strong advocate for the rights of people with mental health issues. Ms. Karpenko obtained her Master of Science degree in psychology from the, I hope I will read it properly, Universidad Nacional de La Plata in Argentina.
Professor Coşkun, sorry for interrupting, but I think we cannot see the slides changing.
Really? Thank you for warning me. You see this?
Now we can see, but could you try going to full screen again?
I think it stops when I go to full screen. So let me continue like this.
Okay.
Please
you can see clearly now.
Yeah. After completing her university studies in Argentina, she worked for 10 years in the development and supervision of community-based mental health services in Trieste. Yeah. In 2000, she joined the World Health Organization, WHO, as a mental health officer, first in Kosovo and then in Albania, where she became the WHO representative to Albania. In both countries, she worked closely with the ministries of health to help establish comprehensive community-based mental health systems. Is there a problem now? Is it on the screen?
There's no problem now, I think.
Yeah, all right. In 2007, Dr. Karpenko joined the Pan American Health Organization, called PAHO, as the sub-regional mental health advisor for the English-speaking Caribbean countries based in Barbados. And in 2011, she was appointed to the position of the regional mental health advisor at the headquarters in Washington, D.C., providing technical cooperation in the mental health field to the entire region. And in 2015, she became the unit chief for mental health and substance use at PAHO. Over the years, Dr. Karpenko has contributed to and co-authored publications in the area of mental health. Since 2019, she is the director of the Department of Mental Health and Substance Use. She is responsible for leading the World Health Organization's work in the areas of mental health and substance abuse. We are grateful for her being with us today. We have 4 discussants: Olga Karpenko, Genn Hepturgun, Jivan Rajendra, and Ferhat Hüseyinov. Olga is a psychiatrist from Russia, Moscow. She is placed in, and she is a psychiatrist, MD, PhD, head of Scientific Collaborations Department in Alexeyev Mental Health Clinic #1. She is also the chair of World Psychiatric Association's Preventive Psychiatry section. Our second discussant is Dr. Genn Hepturgun. He is from Izmir, Turkey. He is a psychiatrist and lecturer at Ege University. And his main area of interest is developing tools to make psychoeducation more accessible. He has proved that in a workshop organized by World Psychiatric Association's section on education. He was the person who arranged almost everything. Ferhat is a medical student, 4th-year medical student at Uludağ University, Bursa, Turkey. He has great interest in psychiatry, especially on topics like major depression, addiction, stigma, and minority stress. He also has some ongoing projects related to genetics, family medicine, radiology, and artificial intelligence. He says his essential goal is to do valuable research in psychiatry field and contribute to science. He is originally from Azerbaijan, studying medicine in Bursa, Turkey. And our 4th discussant is a 3rd-year medical student at University of Malaysia, Sabah. In his words, he says, "I love public speaking and debating and never miss an opportunity to advocate for better mental health. I represent my university debating team and managed to bring my team to the National Intervarsity Debating Finals in 2019, where the theme of the debate was mental health. I'm sure he will do his best today as well." And he says, "I believe Malaysia still has a lot to improve on regarding mental health care, and would love to learn more on how to help his country regarding mental health advocacy." We are 2 moderators. One of them is me, and the other, David Barron. Let me say a few words about David Barron as well. He is Senior Vice President and Provost. He serves as Chief Academic Officer of the Western University and responsible for academic accreditation and budgetary affairs. He has joined the university in May 2018 after serving for 8 years in roles within the Department of Psychiatry at the Keck School of Medicine, including Vice Dean for Global Health, Professor of Psychiatry and Neurosurgery, Vice Chair of the Department, and Chief of Service at Keck USC Hospital. He received his DO degree from the Philadelphia College of Osteopathic Medicine and a Master of Science in Education from the University of Southern California. He is the former Deputy Clinical Director of the National Institute of Mental Health, former President of the American College of Neuropsychiatry and the Group for the Advancement of Psychiatry, and chaired the Department of Psychiatry at Temple University School of Medicine from 1998 and 2010. He was named a National Fulbright Scholar in 2017-18 and conducted his research as Distinguished Chair in Brain Research at the University of Calgary. He also is the recipient of Fulbright Specialist Award, among several other awards. He is also the chair of the section Psychiatry Medicine, Primary Care of WPA. Sorry for having such a long introduction. And now I'm going to stop sharing my to be brief, but not brief at all screen, and hand it over to our dear guest.
Okay. So hello again, everybody. Good day, wherever you are. now I'm trying to share my desk. Let me see if it works. And I should go there. Do you see my screen with a nice young lady?
Yes,
In fact, which is
thank you.
yeah. So thank you very much then for this opportunity, and I have to confess that I put up the slides a couple of hours ago. So looking around and trying to make up my mind of what did I want to say. So apologies in advance if it doesn't come all the way clear and neat from one to the other. But the idea is to share with you. We have a number of emails exchanged with the two moderators, and I thought it was a great opportunity for us to discuss these issues that are of common interest. And so the idea would be to share where we are from the World Health Organization in this issue of what you have there in the slide, right? Mental health at primary healthcare level, opportunities and implications. So I will try to go through that. I won't take 40 minutes, maybe around 30 or even less. And then hopefully we will have time for discussion. That is what I would like to. We know, I hope we all know very well the information that is in this slide, but I think it is useful as a reminder that nearly 1 billion people are living with mental disorders, with depression and anxiety being the most common, and then the rate that increases with exposure to adversity, and we have witnessed this increase recently in the context of COVID, of course. And you have there a bit of the more specific numbers and details in the graph of what are the main conditions and the proportion of them in the full pie. And I think I'm bringing this to your attention because I think it is something that hopefully again for us is very obvious information, but it may not be for those that are not coming from the mental health field. Exactly. We have that, we know that these mental health conditions are affecting people of all age. And I remember years ago using a graph that will of the burden of disease mostly, but we'll start with from birth to older age, and you see here 3% of children under 5, 8% of children between 5 and 9, and then the percentage increases until goes down to 13% of adults over 70 years. So the distribution changes, and the prevalence of the different conditions may also change according to the age and gender as well. But there is a continuum there that we can see. Mental health problems contribute to death. Also, you know, those of us who have been trained in public health, or those of us who have worked in a public health context, we know, or work in the health sector altogether, we know that mortality is what has always driven the agenda, rightly so. No? We have also witnessed it just now with the COVID-19. And so because mental health has not been, in theory, or apparently linked to mortality, then the issues of morbidity or disability caused by mental health conditions has never received enough attention. But we are saying that there's enough evidence already that people with severe mental disorders die between 10 to 20 years earlier than people without those conditions, for a number of reasons that we could discuss later on, but that's well known, and it's known in there were initially studies from high-income countries, but then there were more studies from low and middle-income countries, and that is a common tendency. Suicide, we know is closely related to mental health conditions, and we have 1 in 100 deaths are from suicide, and this information about being the 4th cause of death in young people is always I mean, I'm always in a way surprised that it's not raising more attention or more interest from public health agenda, but also donors or supporters in general, right? That's young people are dying from suicide. Then we have also 3 million deaths from alcohol, 100,000 deaths from drugs. So if we say that mental health is not linked to mortality, we are ignoring facts. And I think that's also important. And there is an obvious impact on economy. The global economy loses more than $2.5 trillion annually because of mental health conditions. Don't ask me what does it mean, $2.5 trillion. My mind doesn't go that far to those numbers, but clearly seems to be a very important amount of funds. And there were a number of studies again showing that there is a return on investment or return on investment 1 to 4, 1 to 5, depending on the condition. And despite that, there is still not enough interventions that are in place. We do regularly monitor countries through the Mental Health Atlas, and very recently we had, a few months ago, we launched the 2020 Mental Health Atlas that was with data from 2019. 171 countries answered to the Atlas despite being in the middle of COVID. And we see that only 25% of countries acknowledge that mental health is integrated in primary health care. And in low and middle income countries, 3 out of 4 people don't receive any treatment for mental health. And you have there, for a mental health condition, and you have there some numbers related to depression and psychosis. The most common one and the most the one that produces the highest disability. And still, then the coverage is very limited, is very reduced. And then when we look at the expenditure, we were talking before about how much one could save if care was available. We see that only 2% of the health budget goes to mental health. And this didn't change from the previous round in 2017. I think it was 190 something, and now it's 2.1. So it's a tiny increase that may be linked to a number of countries reporting here or there, or other issues. So it is a very limited budget still that is there. And the majority of that budget goes to traditional psychiatric hospitals, which means that in most of the countries, there is very limited budget available to develop services at the community level or then at the primary healthcare level. And looking at, in general at funding, just to keep in mind that the international development aid allocates less than 1% of the budget that is going to health. So from all the international aid budget going to health, around 1%, actually it was 0.4 at some time, it's always around that goes to mental health. So there is also very limited attention from that perspective. And you have there a minor increase in policies and plans and steady on legislation. COVID, we know, we are not talking. I was very careful in avoiding any reference because we are trying to do something that is not necessarily related to COVID, but of course, we know that already there have been some global analysis about the increase of people with anxiety disorders, with depression, and among those more affected women and young people. Again, we expected this to happen, and we can confirm it now. We will continue to monitor to see what is happening after, once countries hopefully go back into some kind of what we could say the new normal, right? But the reason why I'm bringing this anyway to attention is because there is an opportunity here that we hope will be taken by countries in using this interest and this increase to develop a system that has been absent mostly on mental health. Now, back to WHO, then we have in 2013 produced the Mental Health Action Plan. That means that we are the World Health Organization has 194 members that are the member states, countries, that decide which are the priorities and what is the way forward, what is the way the World Health Organization should lead countries to. And they decided in 2012 that they wanted to prioritize mental health and that a mental health action plan was needed. And they requested WHO to work on it and to develop it. And so in consultation with innumerable stakeholders, member states, but also associations like yours and many others, academia, many partners, people with lived experience, everybody has an opportunity to contribute to provide inputs, and we have produced that action plan that was 2013-2020. In 2019, countries said, well, the plan is about to finish, but we haven't achieved the targets that were identified. So we need to extend it. And so the plan was extended to 2030 to be aligned with the sustainable development goals of the UN, the SDGs, maintaining the four objectives that were before and updating two appendices. One is about the indicators and the other is about options for implementation. So what countries can do in order to implement what is written in that plan. We will focus a bit around the second one, that is to provide comprehensive, integrated, and responsive mental health and social care services in community-based settings. The first one is about governance and leadership, and the third one is about promotion and prevention, and the fourth is about data and research. But the second one is the one about services and care, and that's what we need to focus our rest of the conversation today. And here you have that we have updated the targets. And if we look at, again, the number 2, we have, we will focus on this later, I think, but just an idea that for each one of them, we have specific targets that, again, were agreed by 194 countries, ministries of health, ministers, representatives from the ministries that come here and say, yes, I agree, or no. Prior to that, countries may say 80% is too high, let's put 70 or let's put 90. And this is a very comprehensive and wide process of consultation that we have. And then indicators are identified for each one of them and guiding then the way to those targets and those objectives. And for each one of them, there are actions, and so actions for member states. So what it is that countries should do. And if you look at this number 2, that is the one we want to focus on, we have there They need to work on service reorganization and expanded coverage. So we need more people with mental health conditions accessing services and receiving the care they need. We need integrated and responsive care. They need to work on that. Countries need to work on integrated and responsive care. They need to work on mental health in humanitarian emergencies, resource planning, and address disparities. And then you have the others as well. And then there are also actions for international and national partners. And here you are, in a way, also represented. So if we focus again on number 2, you are invited to use funds for service delivery and country level, obviously, whenever that is the case of NGOs, for example, or foundations or similar, and then support implementation of programs also during humanitarian emergencies. This, of course, is a summary. There are pages and pages of this, right? I mean, don't think that you are being asked so little. It's much more that is expected from all partners involved in that. But we look then back to this issue that is the objective number 2, comprehensive integrated services in community-based settings. And there are 3 main targets there. The first one is service coverage for mental health conditions that will have to increase by at least half. And if you remember what I showed you earlier about the limited coverage of some of the conditions, then the challenge is big, to increase by at least half. That's a commitment from countries. Then 80% of countries will have doubled number of community-based mental health facilities. And we saw before, I didn't bring the numbers here that we have, but we saw before that most of the budget is in psychiatric hospitals, for example, which are not community-based mental health facilities. And then 80% of countries will have integrated mental health into primary health care. And we saw before, if you remember, that I showed you 25% of countries said that there was some kind of integration. So a lot of work is needed in this field. So what are we doing? We as WHO. You may have come across this. If you have not, look for them. There are 2 publications. The yellow one is from 2008, if I'm not mistaken. The other one from 2013 or 14. So not a new idea. The not new idea is that integrating mental health into general health services is really critical for any mental health reform. Integrated care will help to increase access to care, and also should work to reduce stigma. The simultaneous care of physical and mental health comorbidities will be, of course, facilitated, and will increase also physical and financial accessibility of mental health services, because in general, general health services are closer to where people live, as opposed to the old fashion of psychiatric hospitals that were close to main cities or capitals and outskirts of towns, etc. So this approach should promote universal health coverage. That is what all countries want to achieve. And if these publications are already a bit outdated, the idea of the integration of mental health into general health care has been mentioned or considered since the 70s. I recently came across a paper from Dr. Sartorius describing also the process during the Alma-Ata negotiation, and how a country, by the way, from my region, from Panama, was up to last minute opposing or trying to make sure that mental health was included in the declaration itself. They could reopen the negotiation. It was not there, but then the idea was still to do something, etc. So here we are still discussing why this is important, but it's not new. And in practice, then making these interventions available within primary care mental health interventions available within primary care is achieved by expanding the mental health workforce. And there are two main ways to do that, according to the information that we have from what countries are doing. One strategy would be to build the capacity of general health care staff in primary care settings, that they will be capable to trained to identify, assess, and manage mental health conditions. So it's not just identify and refer, it's identify, assess, and manage until the need for reference comes. And the other strategy that we have seen also in a number of countries is developing and embedding mental health care providers into primary care settings. And I have seen the psychiatrists going on regular basis to the service or nurses, primary care settings, and provide that care there. In both cases, anyway, the extent to which mental and general health care providers collaborate can vary, of course, in an intensity and the modalities that they will put in place. The issue is that there are a number of barriers for this integration, and maybe we can talk a bit about that as well, or strategies to overcome those barriers. Stigma among in the health sector, stigma is huge, and of course in the public as well. One would expect that it's less relevant in the health sector, but in my opinion, it is not, and not only in my opinion, actually. There is inadequate training and supervision of health workers. I hope we will hear from the medical students. I mean, usually psychiatry in low and middle income countries, psychiatry is something that the students have at some point in their career, and once it's over, it's over, and they don't deal with that at all anymore. I carefully say psychiatry because frequently it's just going through ICD or DSM, and that could be it. In many countries, they still do the training in going for a few weeks to a psychiatric hospital where they deal with patients that they will not encounter once they graduate and become physicians. So whatever they studied or saw, they will never apply. So that's part of the issue in the training. The workload, of course, of primary care physicians and nurses is huge. And we always discuss what are the strategies there that could be considered, that could be put in place. And then there is low interest altogether, linked probably with the stigma, no? There's lack of or low mental health awareness in the community in general. So it translates into low interest in those directly invited to be proactive in this area. Lack of medicines, you never know. We say the egg of the hen, right? You don't know if there are no psychotropic medicines available at primary care level because nobody uses them, or they don't use them because there are no availability. So whatever it is, they are not there. Although you don't want also a prescription going on, right? But at least to make careful follow-up, but availability should be, it is a very important component. It is completely separated, this area, the mental health from the physical health in everything, including in this. And then, of course, limited funding because of all the reasons mentioned below, above. There is no funding available, right, for any of that. Now, for the first model that I mentioned earlier, that is the training primary care doctors, nurses, or other medical staff in mental health care so that they can combine their usual responsibilities for physical health with caring for the mental health conditions of their patients. Whoever has been has experience working at primary care level knows that people with mental health conditions are coming to primary care, whether aware of their mental health condition or not, and whether their mental health condition is identified or not. Nevertheless, they are at primary care level. So how can we make sure that this care is combined and is receives mental health care receives the attention? So we when a strategy that would be that is a smart one, but is not so frequent, and we are having also an initiative ongoing on that, is the one of a proper pre-service training for primary care providers, so that we have a sustainable and cost-effective approach to this type of workforce, and it has been shown to be a smart decision wherever it has been done. But is weak. This pre-service, as I was saying before, is weak in many countries, in many contexts, and in many cases, then these non-specialized healthcare professionals needs to be supported by specialist services, whether it is in general hospitals or through community mental health services for referrals, for monitoring, when the cases become complex and there is no response to the first line treatment. In any case, integrated care by non-specialists forms the basis of the mental health, the MHGAP action program that was developed by WHO already many years ago. The guidelines and the intervention guide was launched in 2010. We have reviewed the evidence and republished it in 2016, and now we are in the process of reviewing the evidence of the guidelines. So what we are doing is identified 10, 8 now, depending on the organization, different conditions that are the most prevalent and the heavy burden, but also conditions that we don't have available treatment that is cost effective. And so we developed those guidelines, and based on the guidelines, we do the intervention guide. And with that, we have been training the training has been done in 107 countries last time I checked, and in some countries it's more nationwide or even if regional, but widely implemented. In others it's just smaller initiatives, and the idea is that professionals receiving that training on how to identify, assess, and as I was saying, and manage depression, psychosis, suicide prevention, alcohol, substance use, epilepsy and dementia, and children and adolescents, most common issues, etc. And with that, there is a very clear and easy to follow algorithm that should help professionals. And you have there also, it's been, there is an app that has been developed over time, and then there is a operations manual to because it's not enough the training, but precisely there should be a system in place to ensure that there is peer support or supervision, and that there is and that are psychotropic medicines available, a number of components that there is monitoring and evaluation, etc. So there are different components of this approach, including a toolkit for community workers as well. That is, of course, another level of complexity, but is there. And then slowly we have been developing different psychological interventions that are also components. So initially, the image gap is mostly about medical treatment, but then gradually other components are there. They are recognized and identified as needed in the intervention guide. Slowly, we have been developing tools to facilitate the building capacity also on those psychological interventions. And then so far studies show that the initiative improves knowledge, attitudes, and confidence among primary care providers after the training, and leads to improve systems and engagement with care for people living with mental health conditions. And then it has contributed to reduce what we call the treatment gap, right, of people with mental health conditions that do not receive treatment.
Dr. Kestel, can I ask something? Excuse me.
Yes.
In the previous slide, there was IG standing for intervention guide,
Yes.
if I understand correctly. What is the next one? HIG?
The HIG is the one that was developed for humanitarian context. That's the H about. So based on the evidence available when developed the MH gap, the first one, the intervention guide, we developed another one for humanitarian context that we will see now. The cover in the next slide is here in blue, the dark blue.
Thank you.
And this is it has the particularity of what do we know is needed in the context of an emergency. For the same conditions, what kind of assessment, what kind of management is needed, and what are the main issues or conditions that need to be taken into account. So what you see in this slide is a bit the bigger MH gap package. So what else is needed? And then for some of these interventions, one could think about the second model of integration in primary care that I was mentioning before. So when you promote this embedding mental health care providers in primary care, right? And depending on the context and the resources available, this could be psychiatrists, could be psychologists, could be nurses with training in mental health, could be full-time, could be part-time, could be one that moves around different centers within a district. I mean, we have seen different, different islands and things like that, depending on the capacity that each country has. And then one strategy could be that they have already the knowledge, as we are saying, and they could be trained on specific, for example, psychological interventions or other tools as the ones you have there listed in this slide, that are different tools, and the slide is not complete in terms of, you see, there are a number of psychological interventions and self-help that we have developed. Here you have one picture, but there are a number of them that we have been focusing on trying to see what can we do to scale up care. But having a person working at primary care level trained to use some of them, then you could really promote the scaling up. And they could train other community workers if needed, etc. Hardly that capacity will come from the general practitioner or the physician, the primary healthcare doctor, right? You need somebody else that will help at that level. And in some countries, some of the added resources are community workers, right? That have specific tasks related to mental health. And again, what kind of training do they need, or what kind of extra support might be needed that they could then refer to the primary care practitioners or nurses, and then from there to the specialized professional. So all these boxes that you see there are tools that we are developing, or we have developed to make sure that countries have whatever they need to move on, and there is no need to reinvent everything from scratch again and again. These tools are all available online, and some of them translated into several languages and modalities as well, as I was mentioning. Some are apps, some are just the old-fashioned PDF. So another strategy then is collaborative care, right? A multi-component model of integration to manage depression, but also other common mental health conditions, and usually applied in primary health care. And in collaborative care models, care is provided through a health team with a care manager playing a central role and coordinating the care. For example, the care manager will identify a person with, say, depression, if that's what the team is focusing on, and will identify the person, would link this person with relevant resources available in the community to address the needs of the person, social needs that the person may have as well. Could receive then the person psychological interventions. This care manager will take care of that, make sure that the person receives that. Doesn't mean that the care manager will be the one providing it. The issue of psychotropics, if needed, or any kind of medication, will be followed on, and most of all, the most important part would be the monitoring of how the person is doing over the course of the care, right? By following up on regular basis and with very clear protocols. We are right now working precisely on developing a model for collaborative care that we hope could be really useful as well to countries, together with the other material that we have. The collaborative care requires additional resources because it's a system that needs to be put in place, but seems to be cost effective in terms of coverage and well-being at the end of the day of people in the community. Then we have the issue of comorbidities, and what you see there is a number of slides that I took from a presentation we have recently done in the context of the Global Fund for TB, HIV, TB, and malaria, where we were presenting the evidence that we have about the comorbidity of mental health and HIV, comorbidity of mental health and TB, both ways, and the advantages, right, of integrating the approach. So integrating mental health in health programs is feasible and is cost effective, and will improve both the mental health and the physical health. And clear data is available on particularly on HIV and TB, with again different strategies that could be considered in each case as the more appropriate, but growing evidence and hopefully then growing implementation of this integration. And beyond HIV and TB, of course, there are many opportunities to integrate mental health in specific diseases. We have also developed recently some guidance on the integration of mental health and neglected tropical diseases, for example. Of course, with NCDs, it's obvious the relationship with some of the NCD conditions, with all of them actually. And so, but in the same way that mental health can be integrated into physical disease programs, it can also be integrated into health services for specific groups, right? For children, for women, parents, carers, adolescents, older people. Programs for women health can offer a discrete way of providing mental health and reproductive healthcare to women affected also by sexual violence, for example. That is a known risk factors for mental health problems, but also perinatal programs is a good platform for parenting, but also for children themselves, right? This is then an old graphic that was produced in 2003 by WHO to synthesize somewhere the pyramid of mental health services, right? How the services should be organized. And back in 2000, I use a slide from my time at the Pan American Health Organization. But back in 2003, we were saying, well, if you go on the pyramid, you go up and then more specialized services are needed. They're more expensive and but less frequent in need. And at the bottom of the pyramid are the low expensive, but also high in terms of frequency of need. And after the dark blue, that is the informal community care and the self-care, the first one there you have is mental health services through pyramid, through primary healthcare. So it's back since then that we have been working on that. Now, these days we are working on a World Mental Health Report, and we are working on something like this, which is, please don't quote me, don't use it much around, because this is work in progress, but in a way shows how services, there is a network of services if we want to take care of the mental health of the population, is the specialized community mental health services, the community level, and the variety of those that you can see in green. And then there are services that are beyond the health sector, that are social services and labor and justice, etc., that are under this dark blue or dark green or gray. I don't know what color is it. But then the pink one is mental health in general healthcare. So we have a variety of options there when we talk about integration of mental health in the general health setting. It is in general, but is then also in the specifics of primary care and the various modalities. So I don't know if we need to come all the world in agreement of the one model. I doubt that's even possible. What we need to make sure is that the options are available and that people can, colleagues and the workforce in general can assign the importance and the strategize the capacity to then make it happen and learn from that and change accordingly. This is then my presentation. I lost track of the time, so I hope I didn't go, it wasn't too short, it wasn't too long. But this is the responsibility that we have to work with countries to make sure that the mental health action plan is duly implemented and that targets are achieved and countries really make their way to the care of people with mental health conditions that they deserve. And I stop here and back to you then.
Thank you very much, dear Dr. Kestel. Before going to our discussants, I would like to ask Dr. David. David, would you like to make any comment before we go to our discussants?
Well, just very briefly and start with a thanks, just a wonderful overview. And for the students on the call, it seems to me the greatest challenge that any medical student would want to have would be to engage in this. So hopefully students will be given the opportunity to make a real difference in world health, as this wonderful presentation highlighted, the important need for this. So I'm hoping to inspire our future, our students, to get involved with something that they can make a difference. And they can be the ones that can look back and say it was their generation that began addressing overall health. So I just want to thank everyone, and I'm looking forward to our comments.
Thank you. Thank you so much. We usually start with our senior friends, but if you don't mind, I would like to do it on the other way around, since David has mentioned students, and we are trying to make these organizations for the sake of reaching to students. May I start with Jivan? What would your comments, and if there would be any your questions to this valuable presentation?
Hi, I hope I'm audible. Salutations to all. I'm not sure about the timing in the places. I think I really enjoyed the presentation. It was really nice. I think one important point which the doctor stressed on was the strategies. We need to think of strategies to overcome barriers, especially in like Malaysia per se. Students still don't look at the, I don't know how to say this, but students still don't see the importance of integrating mental health into normal health. Like when they think of our psychiatry posting, they think of it, it's just another module we need to pass. And like we look at mental health and physical health as two separate entities. And that's why I feel the younger generation, there is still hope with increasing mental health awareness and with stigma becoming less and less in the country like Malaysia. The generation after me, even I would say my generation is still a bit fixated on looking at it as two separate entities. But yeah, discussing the strategies to overcome the barriers is an important thing. And I especially like the slide which showed the pyramid where like the lower the cost, the higher the need of it. Like there's a very good slide. And I would think the question I would like to ask is like, what would be the strategies to overcome the barriers from the training sides of medical students? Because I think Dr. mentioned just now that, yes, part and parcel of our education is going to a psychiatric hospital, seeing cases, clicking cases, which we may not actually see in real time and all that.
Thanks, Jivan. Let's see what Dr. Kestel will say about this.
You want me to answer one by one? Okay, or
we, if you like, we can get.
I think it will be easier, so we give some room for others to talk and
okay.
to me only. Then I take note. I will go back to that.
Thank you, thank you. Then let's go to our second student friend. He is Ferhat.
Just first of all, hello to everyone. It's just an honor to be here, and I really very thankful to Dr. Kestel for her presentation because it's too informative, and just again, it's just all presentation remind us the importance of the mental health involved in primary care health. And as a medical student, I also, thought about the insufficiencies in our trainings, because in university we only see some couple of lessons related to mental health and how we have to approach it. And in other internships, we can see that just doctors actually ignore that side of patient. And just as you mentioned, and I also knew that comorbidity is very high in mental health patient, and actually we can miss, just patient can come and maybe we want to try what's happening in that patient, and we can miss this psychological or psychiatric aspect of that patient. And just I also wonder, which strategies or how we can improve that side of medical education for increasing that awareness, and that we can we can use the skills in future, and not me just all just medical students and doctors.
Thank you very much, Ferhat. Interesting approach. Now, may I turn to Olga? Olga, what would you say, your comments, and if you have any questions?
Hello, thank you for the invitation, and thank you for a very comprehensive presentation of this very important topic that becomes very hot, for example, in my country, in Russia. If to link with the medical students, I would say that maybe the problem is unsolved yet, is because still in our mind and in our curricula, psychiatry is perceived as a highly specialized care. So therefore, in the curricula, it is included at the same level as high-level cardiology or neurosurgery or something like that specialized. Although it should be taught already, as for example, we start to hear about diabetes mellitus from the very beginning of our study, about hypertension from the very beginning. So maybe if something like depression and anxiety disorders will be included in the curriculum and will be repeated so often from the first grade until the sixth, through the whole medical training in medical school, maybe the attitude of future doctors will change. That would be my tip to change this. And another thing that maybe one can even, this cannot cross one's mind, the situation, for example, as we have in Russia, because the problem again with very high specialized psychiatric care here, and it is very high specialized in mental hospitals and both in and also in the community care, because we have already 100 years of community psychiatry history in Russia, but it was developed like highly specialized care, and then all this scandal with Soviet psychiatry, and then a lot of stigma, and still, and after that, the law, mental health law was developed, and according to this mental health law, no one but psychiatrist can put mental diagnosis to a person. And therefore, our mental health law protects people from receiving mental health care. They can receive it only from psychiatrists, and it was done for anti-stigma purposes, but in the end, it produces stigma. And now we have a lot of difficulties because everyone, of course, understands that common mental disorders should be treated at primary care level by general practitioners. But according to our law, they are prohibited to put mental diagnoses, and without it, they cannot treat people. So there are some things that are might be very culturally specific and unusual and sometimes quite awkward. And my question will be, because here I have with me already the Russian version of ICD-11. We translated it and issued.
It's not published, so don't show it alone. It's not fully, it's not the English version that is the original is not yet published, so that's a draft yet.
It is not for commercial use. It is the translation of the website, what is on the website. So we did not only something that is officially published. So we connected with WHO. So we have done everything to make it.
I had a meeting a few days ago about all these versions that's why I made a comment, but you were saying something else, I interrupted you.
Yeah, I just wanted to ask maybe, what do you think about the future of ICD-11 implementation maybe, and how it can maybe help the solving this problem? Because as far as I feel, this ICD-11 maybe can make all these mental disorders less specialized and easier to use for general practitioners. And I would like to know your attitude towards this.
Thanks a lot, Olga. Yeah, may we turn to Genn, please?
Hello, thank you very much, Dr. Kessel, for your very informative and very interesting presentation. I think the goals were especially exciting and very impressive for me. While I was listening to the presentation, a different topic and a different group has come to my mind. We have, in my country, Turkey, we have many refugees because of the wars in Syria and Afghanistan. and I think they have serious problems in accessing health services, and accessing to mental health services is even lower, has an even lower rate, I guess so. This integrating mental health in primary healthcare, I think it will contribute to the solution of this problem, the refugee mental health problem. And I wonder if there are any specific strategies or suggestions for the refugees. Thank you.
Yeah,
Okay, now I can go.
please.
Okay, so regarding the questions of the first two ones, right? The questions from the students' perspective. I was thinking, well, what you need to do is to speak up, to talk, to say, hey, I want to learn something else. Say it, say it, say it, and say it, and say it, and say it. And then one day you will be listened to, probably. You need to talk to your, there may be some students association or forum, or it's been a while since I left the university world, so I don't know much about it, but I think that, I mean, it is a shame. I think it is a shame nowadays that students only studied psychiatry once as one unit somewhere lost. A colleague, a friend psychiatrist from Montreal, he says that according to him, general practitioners, they see somebody with a tear and they panic and they call the psychiatrist, right? Because they don't know what to do. So mental health is broader than psychiatry, precisely, right? And so I understand that there is one unit or whatever is the name, and I think it was Olga saying it's a highly specialized, I mean, yeah, if you need to study all that ICD and diagnostic categories and whatever other tools, very sophisticated and perhaps with the pharmacology and a number of issues, that is very complex. I understand there is one, as there may be others, highly specialized. But we talk about mental health, we go a bit beyond that. We talk about the human sufferance, and we talk about a bit of interacting with a human being that you have in front of you as a doctor that is suffering for some reason, and that maybe that sufferance, even if is a physical condition, will have an impact in her mood, for example, in the way she is taking care of her family at home, or in the way she is performing with her or he. I'm using she or her, but I mean, of course, it's generic, women or men, the same. And so how can we ignore that component? And then I think that you know, when we train the MH gap, there is an introduction that is called, I'm looking around to see if I have handy a book, but it doesn't matter. The introduction is about principles of care, taking care of a person. And we start the training to general practitioners or nurses, etc., with basic, how to take care of a person, how to communicate properly, how to listen to a patient you have in front of you, etc. And so there should be something that it is not related to the diagnostic categories that you will study. It is not related to pharmacotherapy exclusively. It is related, of course, but it's broader. So I think that you should talk to your professors and you should say, I want to learn something else. We want to know something else. We want to learn something else. It is changing, but it's still far. And I remember going to visit psychiatric hospitals in my visit to countries, and I see a group of people, young, scary, in the corner of a mental hospital where usually are not very nice institutions, and you are there in a corner looking at people that have been locked down for 20 years or 30 or 50, and that you will not meet ever when you are working in a health center. in the community. So what you need to know is what is happening with the people that come to see you. What is happening with the woman that comes every week with another problem, or with a man that is from one day to the next losing his head, or having terribly pain of whatever, I don't know. I mean, I think that this is really internal advocacy that needs to be done. And this is also valid for the comment. When I was listening to Olga, I was thinking, I have been working in countries where people, doctors who will not get into the cardiology and traumatology and whatever other specialization will end up in psychiatry, because there were numbers available there, while they may not get enough qualification to get to those more fancy professional, specializations, right? So it was like discarded professional. And similarly, nurses that have been punished for bad behavior in their services may end up working in the psychiatric hospital or in the psychiatric area. So it's a lot there going on. So it's highly specialized on one hand, but it's still stigmatized. I mean, there's a lot of stigma to that. And I think the training needs to change if we want to change anything, because all the tools that we are developing is to train, and many others, we are not the only ones, to train professionals once they get out of the university. And I wish they will get the proper training while at the university, right? And you don't need to give them the ABC of mental health care, the basics. So we save the training for things that are really new developments, updates, or anything like that. So what is needed in the curricula then is, I think, mental health, broader than just the specific psychiatric conditions and treatments. The leash of the law that you mentioned, Olga, that's fascinating, but there are similar situations in many countries, not so specific because that's related to the history of your country. But what I mean is that legal frameworks usually are a barrier to move on. And for example, many countries, perhaps it's not so strict, and primary care professionals or psychologists can see patients, but nobody can prescribe apart from the psychiatrist. So a medical doctor fully trained and can prescribe very sophisticated medication will not be able to prescribe some psychotropic medications, which it needs to be properly monitored. We don't want prescriptions to go all over the place, right? But still, only psychiatrists. So that creates a bottleneck, right? Nobody but and so the waiting time is extended, or people don't want to go to a psychiatrist necessarily. They can go to the general practitioner with a stomachache, and the general practitioner can say, oh, maybe you have something else, and there is another condition, a mental health condition being identified. General practitioner can say, okay, let's talk about this, and what about this, what about that, can prescribe something or not, come and see me in 2 weeks, and then we keep talking. Or they can say, go to a psychiatrist. The patient may not want to go to a psychiatrist because it's not so easy to identify yourself as somebody that needs psychiatric care, because again, stigma. So there are a number of strategies there that should be taken into consideration. So changing the law is the strategy. Right? That was a law that was set up how long ago? Well, maybe it's another kind of advocacy, the same that the students need to do among professionals to say, we need to change this because it's a shame. Nowadays, we know that this is not, it should not be only under the responsibility of psychiatrists to take care of mental health care. And in terms of the ICD implementation, we are coming with some guidelines, so hopefully we will be promoting this work soon. I am not so sure that it's going to be through the ICD implementation that you will break some of those barriers, or that you will make more care for mental health available. I suspect that still ICD training is a highly specialized tool and will stay under the responsibility of the psychiatric world mostly, and it may be fine and enough, but still it's one more tool there that could raise some attention. Last but not least, in terms of the refugees problems, Turkey has a very interesting program for many years on mental health in general, with the Ministry of Health in terms of the development of community-based mental health centers and trainings and so on. And then apart from that, there are a lot of efforts going on in the context of refugees. And as you are saying, somebody was asking me about the age in the tool that is the Age Gap Humanitarian. That is being a tool that is being used precisely as I was saying in the context of emergencies, like refugee camps or refugee settings, where you can train primary care physicians on what you need to pay attention to, how to identify stress, how to identify problems related with substance use that are relevant for that context, a psychotic event, etc. So how to manage some of those problems at that level whenever they happen. And a lot of work is going on. We talk about mental health and psychosocial support. It's an area that is very well developed, and there is a lot of material that has been developed and piloted in emergency settings. For example, a new tool that we are about to launch, it has been 2 pilots done in Lebanon with refugees as well. And so based on that learning is that we developed the tool. So there's a lot. I invite you to look in our website, and you can find there, under look area mental health emergencies, you will find a number of tools that are available, and I'm sure they can be used in your context. I suspect several are already translated into Turkish. Thank you for all your comments and questions. From my side, I have 5 more minutes. I have another meeting and I need to switch my mind. So back to you, please.
Thanks a lot. Thanks. Thank you very much. Before giving the floor to David to finalize our meeting, I have one point to underline. Would you suggest any activity for example, WPA sections or some NGOs like ours, Association for Community Mental Health Promotion? This is one point. And another one, you have governments as a separate item, number 1. Would you consider educators as well to look at or to talk to or to do something for? Because, for example, we have only medical students here, but as David may underline, we are not only trying to reach on medical students. We have psychology students, nursing students, social worker students, and their educators need to be targeted as well. This is a modest suggestion. What would you say about this?
Okay, briefly, activities for WPA or the association, the same I said to the students, the same I said to Olga, advocacy is needed. So it's good that you do these kind of meetings, but it's good that you talk to those that we tend to talk to the converters, the converted ones, right? We talk among ourselves. We talk with those who think like us. We also need to talk to those that are not here in the room. I think that's very important at every level for whoever is doing it. I think that the WPA plays an important role, could play even a bigger one because of its presence everywhere globally. I mean, it's the role in advocating for common goals. I think it is very important, and it is done. It needs to be done more. With all the networks and possibilities that you have. In terms of educators, we have a legal binding, our mandate, our counterpart is the Ministry of Health. It is not the Ministry of Education. So when we talk about governments, when we talk about WHO, membership of WHO are governments represented by the ministers of health of each country. Of course, in that context, we do talk to educators, but we talk to educators through ministries of health inviting educators or through partners like yourself. We have done activities with different professors of psychiatry in medical schools in different universities, so that we have this conversation with them as well. And that's part of the work that we do. We are a small group, we have limited capacity here, and so we have one clear mandate. Everything else, like this conversation, is a bit extra of what we can do. The main responsibility is to do the work that I mentioned earlier. And I'm not talking about me, I'm talking about the team here. So that's why we work with partners. We have, WPA has an official relationship with WHO. And in the context of that official relationship, we hope that WPA will also work in the same direction and contribute in the same way. I'm naming WPA because it's us, right? But we have several universities that are a part also on official collaboration with us, and they also spread the word together with us and contribute to do the job that we do, and we do it together. So those are part of the educators we interact with.
On my part, I thank you personally a lot for being with us. And I request my dear friend, David, to close the session, please.
Well, thank you very much. Very quickly, one of the things that I was intrigued as we went through the presentation is some of the strategies. And I wonder if some of the strategies might be that we don't separate mental health, but these are symptoms of overall health. We use cardiology, but chest pain is a symptom. So I'm wondering if part of lowering the stigma might be saying this is health. Mental health is one portion. That's what we've been talking about. I think some of the issues that we are talking about, like lifestyle psychiatry, which is really at the bottom of the period, which I believe is where we need to start, is really that every physician should be engaged in stress as a part of overall health, that some of the language we use may be creating some of the stigma. And to that point, I wonder what Professor Kessler, before she has to leave, is using medical models that medical students understand. Like if someone has heart disease, they might have chest pain, they might have other symptoms, but using the medical model to teach students about mental health, to demonstrate to them very early on that this is no different than cardiac disease, neurologic disease, dermatologic disease, but changing the paradigm where it clearly fits in, so that students see that this is a part of overall health. Those who want to get more involved might get involved with specialty care. But there's so many things to do.
I need to go. It's already my time, but in 30 seconds, the medical model is the one we have been using for 50 years.
Right.
Some others are advocating that we need to change the medical model and move into other models. So I think it's irrelevant the model we are using. I mean, it is important in this context, as you're saying, the medical model, in another context, another model. What is important is that we keep repeating this until we change things the way they are. I really need to go.
Thank you so much. Thank you so much.
A pleasure being with you, and be in touch.
We look forward to working together.
Bye.
Have a good day. Bye-bye.
Bye.
May I ask my dear friends to stay for some time? After we end our meeting at YouTube, we can have some discussion among ourselves for a few minutes, maybe. Thanks to everybody. And